Dr. Moore, it is just a privilege to have you talk to our bereaved parents today. I've been wanting to have you on this call. We've met in years past at some conferences and our work around suicide prevention. And so to have you here today is just such a pleasure. Would you take a few minutes and tell our parents a little bit of your story? How did you come to be involved in suicide prevention work, and what keeps you here? Because it is not an easy field to be a part of. So just talk to us a little bit about you.
Hey, thank you so much for having me. This is such an honor and a privilege to be on your Breathe podcast, and to be able to speak to the bereaved parents that are doing this for. I come at this as a bereaved person myself. It's hard to believe it, but 28 years ago, I lost my husband, Connor, to suicide. Connor was a young man. He was 28, and we were newly married, only 8 months. And we were both, I was working for the governor of Ohio. I was a speechwriter and a policy analyst at the Ohio Department of Health. Connor was a graduate student at the Ohio State University. He'd been recruited by an Irish professor at Ohio State from Ireland. So Connor was not American, he was Irish. And it was a complete shock to me when he killed himself, because here I was in my work covering every cause of morbidity and mortality in Ohio, but we weren't even talking about suicide, every behavior related cause of morbidity and mortality. So I come at this work as a survivor of suicide. I was deeply interested in clinical work and healthcare work and wanted to be on the clinical end of healthcare. And that's where I thought I was headed. But actually, after Connor's death, it really opened my eyes to the suffering around mental health issues, depression, suicidality, trauma, particularly when it comes to child sexual abuse. And as a new Catholic, this was a very complicated place to be, because I really didn't understand my faith that well. I was new. I was still trying to sort of learn the ropes. But I did know one thing. I did have my faith to guide me and to hold me. And when nobody else was there God was there carrying me in his grace. And so I was really led to suicide prevention, I think, from my own experience of loss, but also recognizing a need for people to be engaged in suicide prevention.
Mm. And you've been in this field now for more than 2 decades. And what kind of keeps you here? Because it's not easy. It's not easy.
No, and I'm a clinician, so I'm a psychologist, a clinical psychologist. I'm a clinical suicidologist, so I have specialized training. After this experience of loss, I worked in suicide prevention for a number of years, and then I went back to school and got a Ph.D. in clinical psychology. And I trained under a really famous clinical psychologist. His name is Dr. David Jobs at Catholic University of America, and got this great training. But I had a real fire in my belly to help people. I wanted to change. I wanted to be sort of that new change. I wanted to reflect the new science around how we assess and intervene, and then how do we deal with people in the aftermath of these losses. But I also wanted to train clinicians. So that was kind of my initial mission. But I knew as a person of faith that my faith community, I mean, God was there, Jesus hanging on the cross was there for me, but my faith community really wasn't. And so I would say my sort of second mission in all of this has been to be engaged in work in faith communities, trying to help bring faith communities along. Like I said, the new science around suicide has really taught us an awful lot. And so a lot of the old beliefs and ideas and the stigmas that seem to prevent faith communities from really accompanying and attending people who are suffering, whether it's those who are suffering with mental illnesses or who are suicidal, or those who have lost a loved one to suicide, those really don't exist anymore. But those of us who have this kind of fire in their belly and this kind of passion and mission, we have an obligation to really help our faith communities accompany. And so that's kind of where I'm at right now in terms of the evolution of my own mission.
That's what I've loved about you since we first met, was that fire in your belly. It's obvious you do this with great passion and great joy, if I can even say that, because you know that what you're doing can make a difference for people. And I've admired that and admired that in your work since we first met. So I have some questions I want to ask you that I think might be reflective as a mom who lived had a child with chronic suicidality and then died by suicide. This is so personal to me. So I want to reflect back to you some of the questions and things I think that maybe some of our bereaved parents are experiencing. But maybe first you could just give us a quick update on current research, things that are learning, maybe some things that people aren't aware of, and then we'll come back and chat about some questions that other parents might have.
Yeah, absolutely. I mean, like I said, the science around suicide is pretty new, and with that has come a better collection of data. So data tends to lag behind 2 years, and when we think about the burden of suicide, it's not just the individuals who are dying by suicide. We know that over nearly 50,000 Americans die by suicide every year. And I'm just going to share some slides here, if that's okay.
Yes, please.
But we also know that this has become a real problem. Suicidality, being suicidal, having thoughts and feelings, but then also engaging in behaviors, has been a problem among young people. In fact, young people have traditionally been one of the 3 highest risk groups. And we just look at serious suicidal thoughts among young people, 12 to 17 years of age. And the most recent data, are that about 3.3 million youths have had serious suicidal thoughts that year, and 1.5 million youths have made a plan, and 892,000 youths attempted suicide. So this is a huge burden, and what to do, because these are young people who oftentimes, and we understand that suicide really is it's not necessarily a spiritual crisis. It's not necessarily coming out of the blue, but it's an inability to cope with psychological pain and a real skill deficit or lack of coping skills. And so these are young people who are learning how to cope with the difficulties of life. And I think that we have an opportunity to help teach them these new skills, but this is also telling us that they're being confronted with things that are just so overwhelming that they cannot cope. And as a result, they're resorting to suicide. So I think this is a real problem. Just some of the data, I'm just going to share some of this. This is, not as important, I think, as just sort of the overall picture. The most recent data is actually from 2022. There were about almost 50,000 Americans who died by suicide. In 2021, there were about a little over 48,000. So this is a cause of death that is, as unlike the other top 10 leading causes of death, is not a static cause of death. It's a fluid cause of death. And that's why it's so problematic. And we know that, again, it's, young people, 12 to 17, but, when you break it down even further, 10 to 14 years of age, nearly 600 have died by suicide, 15 to 19 years of age, over 2,300 have died by suicide, and then 20 to 24 years of age, young adults, 4,100 have died by suicide. So this is a very serious problem. Behavioral health, public health, faith. I mean, it's a problem that cuts across all areas of our world. And I think when we think about, females versus males, females have historically have attempted suicide more frequently than males. Males tend to die by suicide more frequently than females because they tend to use more lethal means. The problem, though, in our country has been also with those maybe minoritized populations, marginalized populations, particularly looking at Black females. The rates almost tripled between 2011 and 2021, and that's really troubling. Of course, we saw Hispanic males, adult males, something like quadrupling over this period, but we are seeing, an increase in rates among these populations that are really, very vulnerable, and we really have to continue to, invest and do more to help these individuals.
Hmm. Well, sadly, some of our, bereaved parents have children who are living, with suicidal thoughts, suicidality, maybe multiple suicide attempts. Some have several children who've had mental health challenges and have had a child, die by suicide, and have surviving children who also have mental health challenges. So our parents really come at this from all different angles. I was thinking of, the first time that I was aware that Matthew was suicidal. He was 12, And I was not prepared. He had already been experiencing major depression since he was 7. Time he was a little boy, he had had really serious depression, but I wasn't aware of his suicidal thoughts. And when I was first made aware of them, I thought I just wanted the earth to open up and swallow me. I felt completely hopeless and helpless, unprepared, had no idea what to say. I just remember being shocked to my core that my little boy was experiencing these terrible thoughts of not wanting to be here and wishing that he wouldn't wake up and all those things. So just talk to us first to maybe a parent who has heard for the first time, or just in the last few months, their child express either a wish to not be here or something even more stark than that. I wish I could die, or child of any age, from a little one to an adult who's first time experiencing. Just talk to us, to those parents who are just now walking into this space and might be like me, just shocked,
Yeah.
helpless.
Yeah. I mean, it's unimaginable to parents. I tend, in my private practice, I work with adults, but I'm a clinical supervisor in my university's psychology clinic, where I train all of our doctoral students in suicide focused treatment. One of the 3 empirically supported approaches. Because of the new science around this, we now have treatments for this, but it's very, very new. And the translation into clinical practice is very, very slow. And so one of the things I'm doing is really trying to train all these students. They can get out there and they can treat people, treat young people in particular. But I work with a lot of parents and a lot of children who are suicidal. And it is devastating because these parents, it's so overwhelming to them. It's very difficult for them to manage their own anxiety, their own despair around their child having thoughts and feelings of suicide. That's unimaginable for them. And so I think what clinicians, really need to do a better job of is really working with parents as well. And I think we're getting there. But I think if a parent hears this, from their child, I think, obviously, being empathic, non-judgmental, taking it seriously, listening to them, getting them help that's competent to treat suicide in their child. Because there are a lot of people who are very well trained, but they haven't had any training in suicide focused treatment. So I think I would insist upon that if I were advising a parent who had a suicidal child. But I would also really encourage the parent to look to their own internal resources for managing and coping with the anxiety around this, because it's overwhelming. In fact, it's so overwhelming that some parents, and I hate to say this, but they kind of want to deny it. They don't want to believe it. They will drop their child off for treatment and pick them up because they don't want to hear. And so one of the things that we've had to do as clinicians is we've had to really, in a way that they can hear, help them understand, yes, your child is suicidal, but we're all in this together. There are treatments that work that we can use. And I'm also going to help you, deal and manage your child's suicidality. So the good news is we've got answers to these questions, and not in it by themselves.
Yeah, that's good, because just somehow being able to say that to a clinician and feel the steadiness. If there's a professional who's trained in this, who themselves isn't in denial or doesn't want to avoid it, but is really ready to get into the meat of it with a family, that is so reassuring to feel like, okay, I don't really know what to do, but you seem to have some ideas. So that is so comforting, at least initially. So sometimes what happens is that people's suicidality goes on and on and on, and there may be multiple attempts over a lifetime. And some of our parents have older children. Their child could be 30, 40, even 50. I mean, we have some elderly parents who have walked this very long journey with seriously mentally ill adult children for so long. Just say a word to some of our parents who have just goes on, and it almost becomes a way of life, of knowing that their child may have this chronic suicidality that has not been helped by treatment.
Yeah, that is a very hard place to be. It's a very hard place to be. But the good news is we do have a new science around all of this, and there are lots of resources. As I said earlier, the translation into clinical practice and to dissemination into the mainstream is very slow. And that's why, Kate, what you are doing is so important. And that's why other faith communities should be inspired, faith leaders should be inspired to be engaged in this space. Because, the bottom line is people don't want to hear from people like me. They want to hear from their trusted faith leader. And their faith leader, just with a little bit of knowledge around where to refer people or resources in the community, can really provide a lot of comfort to these families, because it's not just the individual who's suicidal, whether that individual is a child or adolescent or an adult, or the caregiver is, a young parent or an elderly parent. I mean, it affects the entire family system. And that's why it is a community problem.
So can you give us a little detail about what this new treatment involves so that parents who might be seeking help from a professional know what to look for, know even what questions to ask to see if their practitioner is aware of this newer approach?
Yeah, so I'm going to go back and share some slides because I really want to talk about what I do. I mean, it's I do this not because it's self-promoting or I'm promoting a product, but because I know it works.
Right.
Through the science, but also through my own experience as a clinician. It's great when you're dealing with a really tough problem, and suicide is a force of nature and it is a tough problem
Yep.
to address and to treat. But as a clinician, when you've got something that works, it's incredibly reinforcing. And so I was, again, this was very much part of my own personal spiritual journey, and I really believe God's hand was all over this. But when I got in suicide prevention, I felt led to contact Dr. David Jobs at Catholic University of America, and he developed this treatment framework called the Collaborative Assessment and Management of Suicidality. It is one of 3 empirically supported approaches to treating suicide across the lifespan. We've got dialectical behavior therapy, we've got cognitive behavioral therapy for suicide prevention, and then CAMS. And this is what I train clinicians in all over the world. This is actually the website, camscare.com. And what you can do if you are wanting a clinician who has competency in, I want to, you can go to this website, but I also want to let you know there is a new kind of product that they've created called CAMS for Teens. That's specifically for teenagers who are and adolescents who are suicidal, and also their parents. CAMS for Teens, it's not family therapy, it's not couples therapy, it's not parent coaching, and it's not a proxy for the parents' agenda, because oftentimes a lot of parents come to this thinking, very scared, fearful, wanting to kind of control things. But CAMS for Teens is a collaborative, suicide-specific framework. It's child-focused. The emphasis is on the child suicidal drivers. And really the idea here is to create strategies within the family aimed at reducing the child's suicidal risk. So again, we've got this new treatment, and we've got an overall treatment, CAMS, but then we also have CAMS for Teens. And you can find a clinician that is what we call CAMS trained, that is competent in this suicide-focused treatment. You can just get on the camscare.com clinician locator, and they've got a map of all 50 states, and you can find a clinician in your state, in your locale, that's CAMS trained. And I put this up because you can do it yourself and then contact them and then talk with them about it. But I can tell you, if they've had this training and they've gone, they've cared enough to have that CAMS trained status. So they've jumped through many hoops, taken many exams. They've been in trainings with, CAMS care clinician consultants like me. These are individuals who are very competent to treat their suicidal adolescent, adult child, and this is what probably my number one recommendation in terms of finding treatment.
That's great. That's so helpful because I think that just from, like I said, my own experience from talking to so many other parents, we just end up in that place of, if somebody says, well, if you just take this medication, and often it's, people will primarily start with medication and then CBT, and sometimes CBT doesn't seem to work as well with the teenagers, at least in my experience. when it gets really rooted in somebody's heart, it doesn't respond to just this. It just doesn't always respond to logic. There's so much about emotions and trauma and feelings, and so I'm so thrilled to hear that there's some new science approaches that are effective. I think that's what we want as parents. We just want it to be effective. We'll do anything. We'll do what we're told. We'll whatever we're told we'll do to help, because we are so desperate to have our children survive. In fact, we've talked a lot at Breathe about how often as parents, we become hypervigilant. We're so afraid that our child is going to take his or her life that it just becomes the driving force. Then we're watching for everything, and our own anxiety becomes crippling. So can you talk to parents just a little bit about how helpful is it to know their own story, like why they are so triggered even by this, and how they can begin to calm themselves to hopefully then help their children manage their suicidal thoughts?
Yeah. I think suicide is such a complicated behavior. I mean, it's not just one thing. It's not just environment. It's not just DNA. It's not just experiences, traumatic experiences, other experiences. It's so complicated. And I think we're kind of peeling that onion of how to understand suicide, but we're still at the beginning. But I think that again, we've got these great treatments, but I think it's also really important for parents to look inward and think about what they bring to the table in terms of their own experiences with suicide. When I deal with a lot of suicide bereaved parents, I work with a lot of suicide bereaved parents, and it's not unusual for a child to die by suicide, and then for the parents to come into me, and I work with them in the immediate aftermath, sometimes long term. And they will tell me, oh, Uncle so and so killed himself, or my grandfather killed himself, but it's never talked about in the family. And we call this the sleeper effects.
Hmm.
And I think that we have to be very open. I mean, I think using safe messaging, safe words, we don't have to talk about means, but I think talking about these and recognizing that by keeping it hidden and silent, it's not going to protect your children. It's not going to protect you. In fact, we know, and I was so lucky to be part of Dr. Julie Searle's team at the University of Kentucky, where we about 10 years ago uncovered that for every death by suicide, there are 135 people who are exposed to that death. And out of those, there are about 48 individuals who feel close or very close to that individual. And as a result, this closeness confers very serious health risks, such as higher levels of depression, anxiety, suicidal ideation, and then also suicide attempt. So I think we cannot ignore or downplay our exposure, our own personal, or family exposure to suicide. We have to talk about it. But then I think it's kind of like when you're on an airplane and they encourage you, if the mask comes down, take a breath first and then put it on your child. You are not going to be any help to your child if you are not managing your own anxiety, your own fears, your own despair. And so I would really encourage parents who are struggling with a chronically suicidal child, adolescent, adult child to really get into treatment with somebody who understands this, because this can very much be a family trauma.
Oh, definitely.
Yeah. Yeah.
Well, Justin, I think of, in our family, which is the story I know the best, our other children were so affected by their brother's chronic suicidality. Yeah, it was not just Matthew's struggle or ours as parents, but his siblings also carried the weight, carried the suffering, carried the fear, carried the anxiety, and then in the aftermath, of course, carried the grief. But what would you say to a parent who how do you bring faith into that for parents, for families? Say most of the people on this call are people of faith, various faith traditions, but they're bringing a faith into their life journey. And so you said, like, your life experience with grief and post-suicidal grief was not always addressed very well by the church. So what can the faith community do ahead of time? How can they help families who are struggling with suicidality? What are the messages that the faith community needs to give? And what are the messages that the faith community needs to give in the sad eventuality of someone passing?
Yeah, absolutely. I mean, I think we have to treat this mental health issues, mental health challenges, suicide. I think we have to treat it like any other, social determinant. Whether it's houselessness or hunger or other issues that are in our community, we have to talk about it openly. We have to preach about it from the pulpit. We have to have resources in the faith community, whether it's things in the bulletin about Depression Awareness Month or Suicide Prevention Month, or having people come in and speak, experts in the community, having a roster of professionals in the community that know how to treat these issues, know how to treat suicide in particular, because you can't assume that just because somebody's got a PhD or an MSW or whatever, that they're going to be able to treat suicide. They have to have specialized training. But then also having those little like 988 buttons or magnets available. So when the worst happens, people have resources right at the ready. And then the staff, the clergy, the lay faith leaders, the helpers in the community are open to accompanying these individuals who are really walking, these very difficult journeys. That's why I'm a big fan of organizations. I'm a Roman Catholic, and so there's a new organization called the Association of Catholic Mental Health Ministers, started by Deacon Ed Schoner and Bishop John Dolan, both survivors of suicide loss. And of course, your mental health ministry work. I mean, this is the wave of the future for faith communities. And I think we have to really get over whatever the internalized stigma or fear or whatever it is, because that is not going to be helpful. And shutting people down and telling people just to pray more or love Jesus more is not helpful, and it's not accurate.
Yeah.
Yeah.
Yeah. If only it were that, simple, or just that straightforward. Like you said, it's complicated. There's a lot of suffering, involved. What would you say to a family whose child is not very cooperative with a more professional approach? Very resistant to getting treatment, very resistant to medication, very resistant to even talking about their own feeling. Maybe they're afraid to talk about their own, suicidal thoughts, but who just are very resistant to, and the parents are they're pretty much it, trying to help their child.
Yeah. Everyone's different, right? And I think we experience this with a lot of adults too, being very resistant to help, even though they
Yeah, the
know that.
child could be 30, it doesn't have to be a 14-year-old. I mean,
Yeah, right.
your
Yeah.
your person could be 30 or 40 even, and they are resistant to getting help.
Yeah. I mean, I always say to people, I work with a lot of suicidal men, and they will oftentimes say to me, "Oh, I know that my family would be better off if I were dead." And I'm like, "Oh, really? Have you asked them? Have you asked them that question?" And they look at me stunned. And I'm like, "If your wife were suicidal or your child were suicidal, would you want to know?" And they're like, "Oh, absolutely." I go, "Would you do something about it?" "Oh, absolutely." Well, then why wouldn't you give them the opportunity? And so that usually opens up a new avenue. I also think those of us who have been trained in suicide focused treatment know how to work with resistant clients. Now, I will tell you, the treatment framework that I use is going to help the broad range of individuals. It's not going to help everybody, but I think we have to uncover every stone, every rock. We have to try everything. And I think at some point in time, we have to, I think if you're working with a skilled clinician, they are going to be able to help you, and they are going to be more effective than perhaps other clinicians in dealing with these resistant suicidal individuals.
Yeah. We talk a lot in our Breathe ministry about outcomes that we can't control. There's so few outcomes in our lives that we have absolute control over. We might have a little bit of control, and in some places we have very little control. And I think this is one of those places that is a very difficult realization, I think, for family members and parents to come to understand that they cannot 100% protect their loved one from their suicidality. I remember there were some times after Matthew died, and I would hear suicide prevention messages that I know were meant to be hopeful, like suicide is preventable. And I
Mm,
wanted to say, yes, often it is, but sometimes it's not. And
mhm.
I just know as a suicide loss survivor that I had to come to a place even before Matthew died in which I realized I could do my very, very best. I could do everything and I still might not be able to control an outcome. And that took me to a deep place spiritually that is not comfortable. It's very uncomfortable. It is a wrestling and an ultimate surrender
Mm,
that I think, would you agree? Is that your experience that there's
mm.
all this new science? There's some good treatments, and that's so hopeful. And yet, in our spirit, within ourselves, are there some spiritual realizations that we as parents need to hold on to?
I mean, I think there's always hope, and where there's faith, there's hope. Where there's God, there's hope. God never abandons us. God never abandons our loved one. But you're right, we can't always control. And I think before you said the word surrender, I thought to myself, it's always that control surrender dynamic, right?
Yeah.
And I think that coming to that realization, we do everything we can to keep ourselves healthy, yet we're not promised tomorrow, are we? So I think we all live in that as well. We're not promised tomorrow. And if you understand sort of the Buddhist approach, the first noble truth is suffering. Suffering is a part of life. And so I think there are some things that we absolutely cannot control. We do our very best, and we love people, and we do everything we can to help them solve their problems, not be alone, address their suffering. But ultimately, it is up to them. And there are a lot of people in the suicidology world that say, I would never endorse suicide, but I would not want a life without suicide, meaning I would want the opportunity to choose. And I still say to people, suicide is not an act of free will. No question about that. But I do think that God is always in there somewhere. And I think recognizing that, and he never abandons us. So I don't know that that really answers your question, Kay, but that's kind of what I've come to in terms of understanding it.
Well, it addresses the things that I think are even harder to talk about, which is the internal how we process the possibility of losing someone that we love. And yet you said what I absolutely believe, and I say every single time I ever talk about suicide or suicide prevention is there is always hope, because I do believe that. I absolutely do believe there is hope and that we hold on to it with everything that we have. And the second thing is that God never abandons. I absolutely 100% agree. And it is the deepest comfort for me is to know that God didn't abandon Matthew in his deep suffering and um, in his mm, final conclusion that life was more than he could bear. God did not abandon him in that. And God did not and has not abandoned us. And I love to be able to close this for the parents who are listening is reaffirm there is always hope. God is with us, God is present, and he is who we cling to even more than strategies or techniques or research or anything else. God, he is such a personal God who is with us, and he is with our children who struggle. So thank you so much for bringing this hopeful conversation to us. I can't wait to dig into CAMS a little bit further. I know some of our parents will put it all in the chat notes and people can look at it, but thank you for bringing your hopeful presence to this conversation. Thank you so much.
Thank you.